You notice that now we're inside our surgical suite. Once you're in here, this is supposed to be a sterile environment, which means you have your cap and your mask on. Your caps should be identified with your names. For the purposes of this video, I'm going to take my mask off so you can better understand me. Now, once in here, we are going to set up our station. You're going to set up the equipment you need before you bring your patient in for surgery. All of this needs to be ready to go before you induce your patient. Preparedness is key in this part of the procedure. We'll start with the anesthetic machine. Each machine will be different. We're going to use this one as a model. You'll see that every machine will have two sources of oxygen. You have an E cylinder, and you have a hose that will connect to our main oxygen line. Our carrier gas in this case will be exclusively oxygen, so 100% oxygen is going to be your carrier gas for the whole procedure. Your tanks will serve a purpose not only as an emergency gas supply, but also the source of oxygen when you need to travel with your patient. If by any chance you have to travel with your patient in here already hooked up to a machine, or out of here hooked up to a machine, this is your source of oxygen. And if we run out of our central oxygen supply, this is your emergency source of oxygen. Make sure your machine has a cylinder attached to it. Once you know your cylinder is attached appropriately, you will turn on your cylinder by turning it counterclockwise. There will be a pressure gauge attached to your cylinder. That will tell you what pressure is in that cylinder, and the pressure is going to be directly proportional to the volume. A full cylinder should have anywhere between 1900 psi and 2200 psi, and the volume of 660 liters of oxygen. Again, pressure and volume would be proportional. If you come to a point where you have half of your pressure, you have necessarily half of your volume inside that tank. That will tell you how many minutes you can run your patient on that oxygen supply, depending on the flow that you set. Once you've checked your oxygen tank, shut it back off. Take your O2 hose, which is fitted with a quick connect. The quick connect will attach to the oxygen drop in the ceiling. It will only be attached to the oxygen that is meant to attach to. That is the purpose of the quick connect. Once your oxygen supply is in place, we're going to go through the different parts of this machine. We're going to start with the flow meter. The flow meter you will set according to your calculated flow for your patient, depending on the breathing circuit that it's using. By turning your flow meter counterclockwise, and you'll notice a theme, everything that opens in this machine will open counterclockwise, everything that closes will close clockwise. By opening your flow meter, you allow flow to go, and you'll see that you have on this flow meter specifically a ball indicator. Your flow is read at the center of that ball, and you will set that flow based on your calculated flow, depending on the breathing system you're using. If you're using a rebreathing system, the flow should be 10 to 20 mils per kg per minute. If you're using a non-rebreathing system, your flow should be 300 mils per kg per minute. Once you've checked that your flow meter is working, that your oxygen flow is adequate, you follow the path of that gas. You'll notice that in this machine specifically, you have a flush valve. This is an O2 flush valve. It flushes oxygen through your system, bypassing the vaporizer. In doing such, if you're using a rebreathing system, it will dilute your gases within the breathing system, which will decrease the inhalant concentration your patient is getting. Not only it dilutes everything, but it also administers oxygen at a very high flow, which is dangerous for our patients that are intubated and hooked up to that machine. You run the risk of causing barotrauma or volutrauma on your patients. The key message being, do not push this button with your patients attached to the breathing system. Following through, you have your vaporizer. Your vaporizer will be full, so you won't have to worry about filling it. The vaporizer serves the function of delivering a measured concentration of inhalant to your breathing system. You will turn by pressing the button and turning it counterclockwise to your desired concentration. The numbers on the dial will represent the minimum inhalant concentration that you have calculated or determined that your patient will require to stay asleep. Passing the vaporizer, your gases will come to your breathing system. You have the choice of two breathing systems, either a rebreathing system or a non-rebreathing system. In this case specifically, we are attached to the rebreathing system. You'll see that your gases are coming through this part of this connector. Once attached, your rebreathing system is in play. If you're using the rebreathing system, make sure that it is attached to the common gas outlet of your machine, which in this case, this is your common gas outlet. Now, if you're using the rebreathing system, keep in mind that there are a few key components of this machine that need to be present and functional. We'll start with the absorbent. Again, a rebreathing system relies on chemical absorption of CO2 to prevent rebreathing of CO2. In this case, the canister just screws off of this machine. Different machines will have different ways of detaching that canister. You will need to take this off and check the adequacy of your absorbent. And you'll do so by taking a few granules and trying to crush them against each other. If your absorbent is not exhausted, the granules should crumble. They should be able to be crushed against each other. If it comes to a point where they're too hard and you cannot do that, they're likely exhausted and you need to replace it. Simply dump this on any regular trash and fill it up again with new absorbent. Reattach your canister to your machine. Make sure that your attachment is nice and firm. This is one of the most common leak sources on a rebreathing system on a machine. So make sure that is adequately attached. Other components that you need to make sure are present and functional, the one-way valves. These valves guarantee the unidirectional flow of gas through your system, and that is essential to prevent rebreathing as well. If you're choosing to use a rebreathing system, we will use rebreathing circuits such as this. This is called a universal F circuit. It's labeled inspiratory and expiratory, and so are the inspiratory and expiratory valves on your machine. You'll attach them according to their labels. Once this is in place and your common gas outlet is connected to your rebreathing system, you will use this as the means to deliver inhalant anesthetics and to remove CO2 from your patient. You will also need a reservoir bag. You will choose the reservoir bag based on the size of your patient, and the size of the reservoir bag that you should choose is generally 6 times your patient's tidal volume. Tidal volume is 10 to 20 mils per kg. The reservoir bag should be 6 times your patient's tidal volume. The reservoir bag will attach to its port on your breathing system. And again, different machines will have different setups. In this machine specifically, this is where your reservoir bag attaches to. Following the flow of the gas, once it goes through the system, given that we're using a rebreathing system that has a flow of oxygen higher than your patient's oxygen requirements, you will have to have a means of exhausting, of taking away from your system any excessive amounts of gas. This is done through this valve. This is called the APL valve, the adjustable pressure limiting valve, and you may also know this as your pop-off valve. The APL valve should remain open at all times. There's only 2 situations in which you will close this valve. 1, to pressure check your machine. 2, if you need to give your patient a breath. Other than those 2 situations, your APL valve is to remain open at all times. Do not close this valve in the intraoperative period because you may forget it closed. This machine specifically, and your machines will have this additional valve at the back of the APL valve. This is a means of providing positive pressure ventilation without having to close your APL valve all the way. So if you press this button, hold it down, you're able to give your patient a breath without closing the APL. Then you let go, and there's no way you can forget the system closed and that pressure be reflected on your patient's lungs. Also, At the back of these two valves, you have the exhaust that needs to be attached to it. There has to be a means of taking that inhalant-filled gas from the room so we don't have environmental contamination. If you're not at your station, this is done by the use of this canister. This F-air canister will remove your halogenated inhalant anesthetics from the environment. When you get to your stations, you will detach the F-air canister and use our central scavenging line. This is an active scavenge, and you use it by hooking your quick connect to the drop in the ceiling. And again, they won't connect to any different connector because they are meant to be specific. And you will take one limb of this exhaust and hook up to the output of your APL valve. Remember to leave the other port open. This is to be left open to room air in order to equilibrate the suction that you get from here. Otherwise, your machine will get sucked dry of gases if you occlude this in any way. So do not use this in two machines at the same time. Once this is all in place, you'll need to pressure check your machine. We pressure check this machine by closing your APL valve, and you're going to pressurize your system up to 30 centimeters of water. You do so by occluding the end of your breathing system. You can do that by occluding it with your thumb. If your thumb is not holding it shut enough, you can always use your body and hold it closed like that. Just make sure you have a tight fit in order to prevent any gases from escaping from the end of your breathing system. Your APL valve, like I said, is closed, and you can do this in two ways. You can either turn on your O2 flow and wait for it to fill the bag, which generally takes some time, or you can use your flush valve. By flushing your system and filling it up and pressurizing up to 30 centimeters of water, we expect to hold that pressure for at least 10 seconds, which means that the pressure will be reflected on this gauge, pressure gauge, in between the inspiratory and expiratory limbs of this specific machine, and it should hold. The needle should not drop for at least 10 seconds. When I pressurize my system with my flush valve, I'm inflating my bag, and you'll see that this one specifically inflates up to 20 centimeters of water and no further. Once I let go, my gauge drops back down, which means I have a leak on this machine, and I can't pressurize it. At this point, you need to find your leak. This leak specifically is our reservoir bag. Our reservoir bag has a hole at the bottom. When you see something like this, it'll never hold pressure. Therefore, you need to replace, in this case, your reservoir bag. This one is trash. We can't use it for anything anymore. You'll just toss it at any regular trash and replace your reservoir bag for one that should work. We start the process over. Close your APL valve, occlude the end of your breathing system, and pressurize your machine. Again, I'm looking for 30 centimeters of water to hold for at least 10 seconds. Once it's pressurized to 30, check your gauge. And the leak should have been fixed, which it has in this case. You hold for 10 seconds. If it holds, you're good to go. Now, if it doesn't hold and your needle is dropping, you have a leak. Like we mentioned before, the first thing to do is to find that leak. Ideally, you want a machine that is leak-free. If you can't find a leak, you can always assess the extent of your leak by turning on your O2 flow rate. If you can stop your leak with a flow of up to 250 mils per minute, it's considered an acceptable leak, and you can go along with that same machine if and only if you can't find the source of leak in any other way. Okay, once you've checked your machine and you see that it holds, to stop doing what you're doing, do not let go of your thumb. Do not release the hold that you have on the breathing system. You need to open your APL valve. You do this to guarantee that a few steps are taken. One, once you open the APL valve to finish your pressure check, you won't forget it closed. Two, once you open your APL valve, it should relieve pressure, which means that the APL valve is functional. Three, If you just let go of your thumb, any residual inhalant that may be on the machine is going to blow at your face. And 4, if you just let go of your thumb, the system is pressurized. It will blow off some dust from your absorbent into your breathing system, and your patient may inhale that very alkalotic substance, and that is not desirable. And that is the pressure check of the machine for the rebreathing system. If you're using a non-rebreathing system, if your patient warrants the use of a non-rebreathing system, you don't need your universal F, so you can take that out. You don't need this specific reservoir bag. You don't need that. You will make sure that your non-rebreathing system is attached to your common gas outlet. In this machine specifically, remember this is your common gas outlet. You will get this non-rebreathing system from where the equipment is, and that they all will be inside the scrub room. At the back of the scrub room, you'll have your rebreathing systems, your non-rebreathing systems, and your reservoir bags. You will attach your non-rebreathing system to your common gas outlet. And you will attach the scavenge of your non-rebreathing system to your F-air canister. Once you've done that, your non-rebreathing system is ready to be used. You pressure check this in the exact same way as you would pressure check your rebreathing system. You close your APL valve, which in this case is at the back of this system, in between the reservoir bag and the breathing tube. It's a simple switch, very easy to forget closed. So remember to open it every time you close it. Close it, occlude, and pressurize. The difference here being there is no pressure gauge, so you can't know what kind of pressures you're holding. The bag should remain inflated and should hold its pressure. Once you're done, open your APL valve, relieve the pressure, let go of your thumb. As part of setting up your station inside the OR before you bring your patients in, make sure that you have your chosen fluid and your infusion set up for your patient when it comes in. Your fluids and your sets are going to be at a baker's rack at the back of the room, and you'll choose between lactated ringers or 0.9% sodium chloride and an infusion set between 60 drops per mil and 15 drops per mil. It depends on the size of your patient what your choice is going to be. Once you have these two things, go ahead and set them up. Take your fluids and your infusion set, and make sure they're ready to go for when you bring your patient in. And you do that by making sure it's properly connected, pulling out the little blue tab, attaching your infusion set. Make sure to fill the cup about halfway. There's a line that you should see. By pressing down on this little cup and letting go, you pressurize it, you fill it. Hold your line, open your fluids wide and unclip, and you should run your line before you have your patient here. That guarantees that you're not going to forget to run your line and inject air into your patient. Once you've done that, clamp your fluids back up and leave it hanging and ready to go for when you come in with your patient.